Afternoon, my name is Fran, and I'm a student at Cardiff University, and I'm also an Admiral nurse with the Orders of St. John's Care Trust. And today I'm going to be talking to you about transitions in care. I'm literally going to be telling you a story. And this is a story as it was told to me um, by 5 people who are spouses of people that are living with young onset dementia. And I will try as much as possible to tell it in their own words as they said it. And this is the way that I collected these stories. It was a research that I had to talk to them because for professionals to know anything about a situation that people are living in, we've got to ask them. They've got to tell us. And the first thing that I would like to talk about is to talk about transitions and what it is. And when I talk to colleagues and other people and families and many people, many of us just think transition is about a physical move from a place to a place. But actually, I realized as I talked to these people that transition is more than just moving from one place to place. It is about emotions. It is about the things that happen along the way. It's about the communication that happens and everything else, including even documents, the way documents move. Apparently, families do look at this. And so as professionals, these are things that I thought maybe we are very limited in the way that we define transition, because it should be transitions that we talk about and not just transition. And I also realized that there are situations that make transition very difficult for us as professionals and for families that are looking after somebody with living with somebody with young onset dementia, and for the person living with young onset dementia as well. And there are situations that are different for everybody. People are different. Their situations in lives are different. And so transitions are very complex. So for example, I'll give you examples from these stories that I talked about. The situations and circumstances that are causing the transitions. For example, in the case of one lady, Alana, she really struggled with these transitions because she had actually moved her home to a bungalow where she thought her husband would stay with her at home, but no, she couldn't, because the situation was just getting more and more difficult. And for other people, it was the way the transitions occurred. For example, Mary, she didn't have a chance to look for the place herself that her husband would go and settle into. She felt like she wasn't involved at all. All that power and all that responsibility was taken off from her. And that caused a lot of difficulties in that transition. What else is going on around them also matters. For example, in the case of Ellen, the children were just growing up. She had all these children 3 children that were just starting to get to be adults. And the youngest was still in school, A levels. And the older ones were moving away from home. So all this also, there were other transitions that were going on in their lives. And so they were really difficult. The same for Mary, who had 3 young children. They were still minors, and that was really difficult as well for them. But the most difficult thing for every one of them, for all these people, was that they lacked support. Professionals didn't provide enough support. And when they talked of professionals, they talked about social services, they talked about mental health teams, they talked about the general hospitals that they visited. They talked about other organizations that give support, such as Dementia UK, such as Alzheimer's Society. And they felt they hadn't got enough support to actually carry on. Now I'd like to share with you some of the themes, the main 2 themes that I found to be really prevalent in these people's lives. And one of them was dementia grief, which had an impact on transitions, and vice versa. So the transitions also caused dementia grief for these families. And dementia grief was defined by all these people as grief that is ongoing, and it started from when they started to notice the symptoms, when the person started to get forgetful, and when they started to change in behaviors, and they really struggled with that, till now the person is still in a care home. Despite that this person is alive, they still struggle. And what made it more difficult for them was that this person could not hold a conversation with them, could not recognize them, could not do the normal things that they used to do with them. And that's when it was so difficult and made it into dementia grief. And as we go on, I'll tell you some of the statements that they said while they defined it. And then there was something else that really puzzled me. Do-it-yourself dementia. These are Mary's statements. Mary actually talked about this as a term that she and the children brought up and put into in their own words, because they were defining situations that they were left in by all professionals. They felt they were left in. Mary is the lady who had 3 young boys, and they were all minors. They were 12, 14, and 15 at the time that their father was diagnosed. This means they actually were younger when the symptoms started. And so she was trying to protect the children. She was trying to protect her husband. She was trying to protect herself. And the worst thing was that whenever she approached professionals, and this is in her own language, initially for a long time, she was ignored. She was told all was okay. They did all these investigations in terms of the scans. They didn't show anything. Instead of the memory tests, they didn't show much difference. And so he was deemed to be okay. And yet at home, they had all these difficulties, especially with personality changes, which would at times bring up aggression in him. And so that was quite difficult. So some of the words that were shared with me by these family members describing dementia grief as an impact on our transition, it's like the grieving process when somebody goes into a care home. And as professionals, at times we just think that when the person goes into the care home, their wife would feel better or their husband would feel better. That was not the case for Alana. Alana actually felt that she had lost him completely. Now that she had lost him, yes, he lost his capabilities. And now again, she had lost him because he was going into care. And so she felt like she didn't have a husband anymore. Ellen as well expressed that she was losing her husband. She had been with him for 36 years. And now she had to change all their future plans because he couldn't do as they had thought. She was still in work, and she thought they had been planning that at 55 they would both retire, but she couldn't retire at 55 anymore because they still had a mortgage. She still had young children, and so she still had to do all these things alone without a husband. They couldn't make the decisions together. And I also talked to Thomas, who talked about other things that we don't normally think about. We don't normally talk about sexuality with our people that are living with dementia in general. And yet this is something that was mentioned in this storytelling. He talked about when he visits his wife, the emotions that he gets. He can still hold her hand. He can still walk about with her, but actually he can't kiss her. He can't cuddle her. There's no intimacy anymore. And this is something that as professionals, maybe we haven't thought about, but we need to start thinking about. He felt in that way, he was actually believing. He was still young. He was a 60-year-old gentleman. And so to him, at this stage, this was still quite important. And yet this need couldn't be fulfilled anymore, which made it think about the types of institutions that we have. For example, our care homes, most of them are designed to have a single bed. They're designed for us to pop in and open the windows and open the doors whenever it's necessary and whenever we feel we have to check on them. We have all these observation times that are timed every hour, maybe every 30 minutes. We should be checking up on this person. And we do, even if they've got somebody with them, and especially when they've got their spouse. So this was also something I thought we needed to really think about: sexuality and sexual needs of people that we're caring for. In talking about dementia, DIY dementia, these were definitely Mary squares. However, every one of the participants did talk about something that happened to them that just seemed like it was also falls under the do-it-yourself dementia phrase. So for Mary, there had so many incidences that they'd reported to many to many professionals around. For example, she had approached social services several times. She told the children when she was desperate to report themselves in school that they actually have problems at home, and this had been done. And she had gone to the GP several times, and all this time she felt nothing had been done that would actually keep her safe, keep your children safe. Instead, what she felt was happening and had been told was that she had to change. Her children had to change so that her husband could be safe at home. But actually, they were all not safe at home. They were all not safe at home. And so they found strategies to deal with it themselves, the situation themselves. For example, her husband would wake up at night. He wouldn't sleep. He would be going around in the house. If he found somebody in bed, he would just start attacking them physically. And for her and the children, this was really distressful. So they were looking after each other. They were looking out for each other. They would place furniture behind the doors. But if he managed to push it, then they know that they're in trouble. Someone is in trouble. And this carried on for a few years, for a number of times. The only time they ever got taken seriously, in her own words, Mary, was the third time that her youngest son attempted to take his own life because things were too difficult at home. And this was quite sad for me to hear that a family can get to that extent when, as professionals, we're still trying to help. I also spoke to Ellen. They got a diagnosis around Christmas, on the Christmas Eve, and were told that they would get somebody allocated as a care coordinator. And they didn't have a coordinator until after February the following year. And that gap was really difficult for them because her husband was presenting with behaviors that they didn't know how to manage. For example, which might seem very easy, he only would wear a certain color of clothes. He would only wear blue clothes, and he would settle if he had blue clothes on. And Mary struggled because he was a professional. He had all these suits. He had all these different color clothes. And normally we have different color clothes anyway, but actually he had changed. Blue was the only color. Eventually, she learned that blue seemed to calm him down. So she had all these other clothes in blue, which she had to also learn from Googling around and finding out if there were any ways that she could help her own family. And I also talked to Maxwell, who brought this point up that I'm still thinking about every day, because he said he'd never experienced any services who actually came across as understanding the clinical needs of a young person with dementia. Maxwell's wife is still in her 50s. She's still 55 now, I believe. And she was diagnosed quite early. while she was still in work, had to leave work because she had all these symptoms and couldn't carry on with her work. She couldn't coordinate anything anymore. She had been in a mental health ward. This was the third time she was readmitted. First time she was discharged to a home, which wouldn't meet her needs. And so she was moved very quickly, urgently, to another home that was supposed to, but within a week, that home had failed as well. And so she ended up back in hospital. And then she was discharged to another home that couldn't meet her needs as well and ended up back in hospital. When I spoke to Maxwell, she was in hospital. The discussions were about where she goes next. And Maxwell was expressing that at this time, he was actually struggling because he felt that the teams just did not understand this lady's needs. And so they were suggesting any type of home, any type of, and he was expressing all the needs that made the other areas break down and saying these are still the areas that are still very important and they need to be sorted. He also expressed about the difficulties he had while she was in hospital, while she was in the care home as well, that the care home staff didn't seem to understand some of the needs. And at the same time, when they tried to get support from the mental health teams, they didn't get that support either. And so, in a way, he was also saying the mental health teams seem to have let the care homes down. So they let care homes down, eventually failed to provide this support they needed to because they didn't have these strategies in place to do so. Another area that was also mentioned that I met by all these other family members, because they all had been working at some point, actually contacted the police as well. So they also all mentioned about the police. And they had most of them, for example, Mary had difficult situations with the police. They just didn't understand that this gentleman had all these behaviors that he needed support with, and he wasn't a criminal. And the way he had been treated, despite that he had physically attacked someone in the home, felt like he had been treated like a criminal. Ellen's husband had had the same experience, and so had Maxwell's wife. Had almost the same experience as well of being handcuffed, of being put in a police car and taken into a police cell before they were moved anywhere else. And so these are all issues that were raised by these families that we, at some point, need to be really addressed, thought about, and see if there is any way that as professionals, we could improve the way we work with families that are living with young onset dementia. In conclusion, I think it's worth remembering that whenever we're working with a family that's living with young onset dementia, it's the whole family. The person is in the center, yes, but they're not alone. There's a system, a whole system, the family living with them, the neighbors around them, the schools that's catering for their children, every other part that's connected to them need that support as well. And when we think young onset dementia, we should always think complex, because they are complex, because they are younger people. They still have a lot of things that they're able to do, that they could be doing, and that the people around them are affected and impacted on in very complex ways as well. And the transitions are multiple and complex too. And another point is that DIY dementia cannot keep going on. It has to stop somewhere. And that for us all as professionals to realize that no one size fits all. No one size fits all. And so we have to be dynamic, and we have to be thinking about individuals as individuals with individual families, with individual needs, and come to how we can support them. In order to change their experiences, we need to help maintain relationships for them, their relationships with their family members, with those that are around them, with their communities, their relationships with us as well needs to be maintained as professionals and not break down. We need to support them, the families that are caring for them, so that they get to a point where they feel comfortable to keep caring for this person, even though things are difficult, because we are there and we are accessible and we are available to them. And thank you.